So my name is Richard Turner, and I'm a consultant dermatologist, and I've been practicing in Oxford now for more than 20 years. My main interest is in skin cancer, dermatological surgery, and Mohs micrographic surgery. And I have been doing that consistently since about 2000. My volume of work that I tend to do between 50 to 200 per year. And the numbers increase year on year. So I've got a fair amount of experience of Mohs over the past 20 years. I tend to focus on Mohs surgery away from the actual eyelid itself, but otherwise have tackled cases on all body sites, including even genital skin. Mohs has been around now for 60 or 70 years, in the fact that it was first thought of in the 30s. And the surgeon who came up with the idea thought about a new way about how to look at tissue which is taken away from patients. So basically, in the past, what used to happen is people used to take out a skin cancer, take a very thin slice out of it and see whether the tumor was in there, what it was, and whether or not that tumor was at the edge of what they'd taken out. The problem is that when you do that, it's a bit like a loaf of bread. You're only actually looking at one slice, and one very, very thin slice out of the whole slice of bread. And from that, the pathologist is saying, did I get it? Didn't I get it? Well, he might have got it in that slice, but maybe in another slice from the other end, you may not have got it. But because he doesn't look, he doesn't know. So Mohs, because he was very young, hadn't been indoctrinated by the way that people do things. And so he had his own ideas. And he said, actually, I don't care what's happening inside. What I want to know is the tumor at the edge? And so instead of taking out a slice of bread, he looked at the entire crust. And effectively, that's all Mohs is. It's a different way of slicing up a loaf of bread so that you can see whether or not that tumor is on the edge of the piece of skin you've taken out. And you're seeing all of the edge, not just that thin slice that a normal pathologist would take. And so you can say with much, much greater confidence that you've got rid of the skin cancer. And that's really important because, you know, if it's on the end of your nose and you cut it out in the conventional way, because of the uncertainty that I've explained, you know, the pathologist is only taking a little bit of out, you have to make a big hole. You have to put a big safety margin on it to be sure you've got it all. And so on critical sites, it's a real problem, which is why Mohs is so important in these areas. So nose, lip, in and around the eye, a lot of facial areas. Mohs is indicated just so that you can take something out with some certainty, and also just to make a small hole. You know, the interesting thing about Mohs, as I said, is you can take out a very narrow margin, less than 1 millimeter, and then have a look at it under the microscope. And if that little bit of crust has got a little bit of tumor in it, you know exactly where it is, and say, so rather than take out a great big chunk all the way around, you take out that one little piece from one corner, and you keep on going till it's gone. So it's a very neat way of taking out all that you need to, and take out a way that is very confident, and you can say with certainty, or almost certainty, that you've got it all. So we use Mohs micrographic surgery, as I've just said, mainly in areas which are vital. So central face, around the mouth, nose, ears, ear canal. So key places on the face. You can use it on other body sites. So genital skin, again, I've got experience of doing Mohs there. That's much less common. You can use Mohs when you have tumors that people have had a go at and they've failed to get them out. So incompletely excised skin cancers, Mohs is almost treatment of choice. And you can use Mohs in skin cancers that you thought you got rid of, and yet the tumor recurred. So recurrences, that would be an indication for doing Mohs. Finally, I guess if you're 25 or 30 and you've got a skin cancer on your face, you want it removed as conservatively as possible, with as small a hole as possible, with the greatest certainty of cure. You know, operating on young skin is harder because you don't have your creases and fold to hide your scars in, and your face is tight. There's no laxity to use to close the hole. So if you're working on young skin, anyone younger than me, I suppose, then Mohs also has an indication. So to summarize, I guess, young skin, critical sites, recurrent tumors, or tumors that have been incompletely excised, then that's where Mohs is most indicated. And the tumor types that we tend to do primarily for Mohs is basal cell carcinomas, and that's the commonest skin cancer that we see. 80% of our skin cancers are BCCs. You can do Mohs for other skin cancers, but the primary use is for basal cell carcinoma. So the majority of Mohs procedures can be completed in 3 or 4 hours. The surgery itself is actually usually pretty quick. What would happen is you'll be awake, you would come into a theatre suite where we would consent you, check the site, take some photographs, and then make that area numb. And having been giving local anesthetics now for 30 odd years, there are ways and tricks that you can give local anesthetic, which is on the whole pretty painless. So you can numb up quite large areas of skin. Once you've done that, then what you do is you gently scrape away what tumor you can see and feel, and that guides you. It gives you some idea about how much skin you need to take on your first go. And then you cut that tumor out, and then you take that piece of tissue up to the laboratory. Whilst you're waiting for that tissue to be processed, you'd have a dressing put on that wound, and you would go to a recovery area where you would sit whilst you wait for me to get the results back from the lab. And then what would happen, and in about 60 to 70% of cases, that's all you would need. Your tumor will be clear. And then a second case might, a second level might require in say 20%, and then maybe a third, fourth, and fifth. But the chance of that is actually very uncommon unless you've had a lot of surgery beforehand and the wound has been disturbed by lots of people having a go at getting it out. That tends to be ones that tend to have multiple goes, or if the tumor is very neglected. What I didn't mention is then once you've created your hole, you then have an issue of reconstruction. And so most of the time, your reconstruction will be done by myself in dermatology. And as I said, I've done between 100 to 200 Mohs cases a year for the past 10 or 15 years, and overall practicing for more than 20 years. And so I've reconstructed an awful lot of people. And that would involve a few approaches. What you might find is that the hole is in an area which naturally heals very nicely by itself. So if it's on the side of your nose or anywhere it sits in a groove, then wound healing there can be very, very good and cosmetically very acceptable. But sometimes the hole isn't on that sort of site, and so you might just close the wound directly. So you'd basically sew the two sides together. And the nice thing about skin is it stretches. So although it might be a bit tight on the day, the skin would come together very nicely, and you would usually be left with a fine line. Sometimes the hole's too big to do that. And so what you would do is you would move some skin that was adjacent to the hole and move it into the hole to help move loose skin into areas of tightness. And we call those flaps, and we do those sometimes. And then occasionally the hole is very big, and what we would do is we would borrow some skin from elsewhere and we would sew it into the hole, what's called a skin graft. And skin grafts can often do very well as well, with high success rates, 80, 90% success rate. So they can do well too. And then once you've had your surgery, it depends on what you've done to someone, but generally you'll feel tired and slightly washed out for a couple of days, because you probably would have been worrying about it for the night before, so you won't have slept that well. And going through any surgical procedure is stressful. But maybe after 2 or 3 days, you'd start to feel a bit more comfortable and less tired. The wound at the very start may be a bit painful, but it's often surprisingly not, particularly in wounds that we graft or wounds that we let heal by themselves, where there's no tension on the skin. So you'd be pretty pain-free. But if you are in discomfort, then usually paracetamol does the job. You can take opiates, so cocodamol if necessary, but actually that's rare. We tend to discourage people from taking drugs like Brufen because it makes your skin leak a bit, so you could get a bit of bleeding after the procedure. Bleeding does occur anyway, so you get a little bit of seepage. That's not unusual, but heavy bleeding is rare, maybe 2 or 3%. And were that to happen, you just press on the wound and it stops almost always. It's very rare that you have to go back and re-explore a wound to see if there's been a problem. Infection does occur, so we know that 2 to 3% of wounds do become infected, and the bugs that they get infected by are usually bugs that live naturally on our skin. So it's usually the patient's commensals, we call them, have colonized the wound. And so that can happen, particularly with more drawn out procedures or more complex repairs. And then I tend to use soluble stitches for nearly all my work these days. And therefore there's not normally a need for stitch removal. The stitches will fall out of their own accord over a week or two. You can bathe and shower after 48 hours in the majority of cases. And so you can keep the area clean. And the act of bathing, I think, does reduce wound infection. It helps the stitches to dissolve. And so all in all, it can make the wound quite tolerable to manage. And then we know that wounds mature over a period of 2 years. So the majority of the improvement occurs within the first 3 months, but after that, it will still continue to improve and continue to fade. So you don't really know the full outcome until 2 years, but you can get a pretty good idea after the first few weeks even. So the surgeons who repair these defects, whether they're dermatologists or plastic surgeons, use very similar techniques. So I think the problem is that when we think about plastic surgery, we think about cosmetic surgery, which isn't quite the same thing. So in this instance, we will be using the same techniques. Times that I would use plastic surgeons is if the hole is very big and it involves bone or has made holes in vital sites that require people perhaps having to go to sleep to have their holes reconstructed. So I would very much be using my plastic surgical colleagues in that instance. And very occasionally you can create a hole in a difficult site that needs microsurgery to perhaps reconstruct the side of a nose using a piece of ear and the blood vessels attached within that. And we do not have those skills in dermatology, so we couldn't do the sort of microsurgery for that. But I would say I probably reconstruct between 80 and 90% of the work that I do.